Welcome to the HWTAC webinar series. This presentation is entitled How to Use IPUMS to Study the Health Workforce, and it was presented by Julia Drew and Sarah Flood on February 25th, 2020.
Hello, my name is David Armstrong, and I'm with the Health Workforce Technical Assistance Center. And today's webinar focuses on how to use IPUMS to study the health workforce. And today's event is co-sponsored by Academy Health's Health Workforce Interest Group and IPUMS. Next, Davis Patterson, the chair of the Health Workforce Interest Group, has a few announcements. Afterwards, we'll move on to our featured presentation by Julie Drew and Sarah Flood from IPUMS. Davis?
Hello, David and audience. My name is Davis Patterson. I'm faculty in the University of Washington School of Medicine, and I'm the chair of the Academy Health Workforce Interest Group. I want to thank our guests from IPUMS for speaking on using their data for health workforce research today. And I also want to thank the Health Workforce Technical Assistance Center for hosting the webinar and really expanding the audience reach with this platform. I'm really grateful for that. So the Health Workforce Interest Group at Academy Health has a mission to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. And I invite everybody to attend our session in Boston at the Academy Health Annual Research Meeting. And our session will be on Monday, June 15th. The final agenda for the whole meeting is being determined still, so I don't know exactly what time on that day, but it's open to all attendees of the annual research meeting and no charge or anything. It will just be in the schedule and you can drop in for our session. You could also join our interest group. I invite you to do that, and that comes free with Academy Health membership. And we do professional development and networking for health workforce researchers and connect with policymakers and other stakeholders. I invite you to contact me. There's my email address, or Janet Kaufman, who is our vice chair at UC San Francisco, for more information about the Health Workforce Interest Group. We also aim to do more webinars like this in the future. And if you have an idea about a health workforce research-oriented webinar you'd like to see, also, please feel free to email one of us. So stay tuned about that. And now I will turn it over to our presenters.
All right. Thank you, David and Davis. My name is Sarah Flood, and I will kick off the IPUMS component of this webinar. And we just want to first thank the Health Workforce Interest Group of Academy Health and the Health Workforce Technical Assistance Center for organizing and hosting this webinar. My colleague Julia Drew and I are delighted to be joining you today to talk about using IPUMS to study the health workforce. Our plan for the webinar is to introduce you to IPUMS, talk about using IPUMS data mostly from the United States and applications for studying the health workforce, and then we will give you a brief tour of the IPUMS data access systems if we have time. All right, I'll start with the introduction to IPUMS and the data we make available to the research community. IPUMS is the world's leading provider of U.S. and international census and survey data. We code data consistently across time and place. Our integration and documentation makes it easy to study change, conduct comparative research, merge information across data types, and analyze individuals within family and community contexts. All data and services we provide are free of charge. At a high level, this is how IPUMS works. You first access the data and documentation via web-based data dissemination systems. Then you build a customized data set by choosing the years of data and variables that you want in your data set. And this is in contrast to getting all of the variables in a data set from the original data producers. Once that customized data set is ready for you to download, we send you an email. You download the data at your convenience and analyze it in a statistics package. We also have extensive tutorials for using our system, a user forum where you can ask questions and browse previously asked questions, and a user support team dedicated to answering IPUMS user questions, typically within a couple of business days. The data we make available at IPUMS has been collected by other entities, generally statistical agencies, and it is accessible elsewhere. Yet we still have more than 100,000 users around the world. Here are some of the benefits of using IPUMS. We harmonize data so that it is consistent across time and place. We provide comprehensive online documentation that is available at your fingertips. We allow users to build data sets that contain only the variables they want. We also have online data analysis tools. We won't discuss these today, but you're welcome to explore them later. Finally, we pride ourselves on supporting the use of the data we make available. In short, we try to reduce the startup costs of data analysis so that you can get to your analysis more quickly. IPUMS has 9 data products, each with different content. While the content of all of our data products is unique, the sites work similarly, so if you learn to use one, you learn to use them all. I'll briefly describe the various data collections. So IPUMS products fall into 3 broad categories: census, demographic surveys, and health surveys. USA provides decennial census and American Community Survey microdata. These are person and household level data from 1790 to the present. NHGIS provides summary or cross-tabulated data for geographic units such as counties, cities, and census tracts from 1790 to the present. International provides census microdata for more than 90 countries in the world. CPS, or the Current Population Survey, is a household survey used to measure unemployment, poverty, and insurance. Approximately 55,000 households are surveyed monthly. ATUS is the American Time Use Survey. It provides time diary data over a 24-hour period and includes detailed information about what activities people are doing, the duration of those activities, where they occurred, and who respondents were with during those activities. IPUMS International is also adding labor force surveys to its collection. NHIS is the National Health Interview Survey and provides the principal source of information on the health of the U.S. population. Between 35,000 and 50,000 households are surveyed annually. This product has over 17,000 variables related to health, socioeconomic status, and demographics. MEPS is a medical expenditure panel survey, which provides detailed information on health conditions, health expenditures, and utilization, as well as demographics for approximately 12,000 households annually. The household survey is supplemented with data from medical providers and employers. DHS, the demographic and health surveys, provide microdata on health status and care data for women of childbearing age, their households, and their children under the age of 5. DHS is fielded in poor and middle-income countries. And finally, PMA, or Performance Monitoring and Accountability, is a Gates Foundation-funded survey focused on family planning, water and sanitation, and menstrual hygiene. It is fielded in Sub-Saharan Africa, India, and Indonesia. Our focus in this webinar will be mostly on USA, CPS, ATUS, NHIS, and MEPS. Now let's dive into some details about how to use IPUMS data to study the health workforce. We'll start by discussing some considerations when defining the health workforce. At the highest level, there are 2 ways to identify the health workforce, either directly or indirectly. Using USA, CPS, ATUS, and NHIS data, you can directly identify the health workforce using occupation and industry variables. Using MEPS, you can indirectly identify the health workforce by using the characteristics of healthcare providers reported by individuals who receive care. I'll spend most of my time talking about direct identification. Later, Julia will illustrate different ways that IPUMS data can be used to study the health workforce, including an example focused on MEPS, where indirect identification of the health workforce is required. So first, on to direct identification of the health workforce. To directly identify the health workforce, you can use information about occupation and/or industry, depending on how you define the health workforce. We'll spend most of our time on occupations to illustrate the issues around comparability and granularity, but it is up to researchers to define the health workforce in the way that is most appropriate for their research questions. If you're coming to IPUMS to study the health workforce, there are a couple of things that will be helpful to know as you begin browsing the variables available in the various data collections. We will talk about 2 specific dimensions in turn, comparability and granularity. Both are related to ways that occupation variables are coded. The first dimension is comparability, where we focus on harmonized versus unharmonized variables. The second dimension is granularity, where we focus on detailed versus coarse coding. Unharmonized occupation codes are essentially occupations as they are coded by the data provider. They're a great choice if you want the most recent year of data, a single year of data, or a small set of years that share an occupation coding scheme. Unharmonized occupation variables have as much detail as is available in the data. The amount of detail that is in different data sets is the second dimension we'll get into in just a few minutes. Occupation codes are updated to reflect the types of jobs that people do for pay. As jobs change over time and occupations emerge and disappear, occupation coding schemes also evolve. Since 1950, there have been 7 occupation coding schemes, with some updates to the coding schemes more substantial than others. If you use unharmonized occupation variables across years, you will have to navigate the differences in coding schemes yourself. Rather than overcome those changes over time in the way that occupations are coded, you can use IPUMS. Harmonization, or coding data consistently across time and place, is the signature activity of IPUMS. In contrast to point-in-time analyses that are great with unharmonized occupations, researchers who want to pool data over time to increase sample sizes or look at changes over time may find our harmonized occupation variables more useful. There's a trade-off, though. In the harmonization process, occupational detail is sometimes lost. Let's talk a little bit more about how IPUMS harmonizes occupations. When occupation coding schemes change, the Census Bureau describes how adjacent years' occupation codes map onto one another. They describe these mappings in crosswalks. Rather than every researcher needing to map out occupation code changes across schemes, IPUMS does this for the research community. So for researchers who want to use data from different years that use different occupation coding schemes, harmonized occupation variables will come in very handy. I want to briefly show 2 examples that illustrate what happens during the harmonization process. Here's an example where there's increasing detail in occupation codes over time. In this case, the 2002 code of 130, which represents human resources managers, is on the left. In 2010, this occupation split into 3 separate codes. To harmonize the 2010 occupation codes backwards into the 2002 scheme, we simply assign all of the 2010 codes to the single 2002 code. Now here's an example of occupations that were separate in 2002 and got combined in 2010. Now to harmonize the 2010 codes into the 2002 scheme, we have to make a choice between which of the 2002 codes to assign that single 2010 occupation code to. We use the Census Bureau crosswalks along with occupation size to make this decision. So this wraps up the first dimension of occupation and industry codes that one must consider, comparability. That is, whether to use harmonized or unharmonized versions of occupation variables. Now we will turn to the second dimension of granularity, which considers detailed versus coarse occupation coding. Detailed occupations are available in USA, CPS, and ATUS. The variables OCC and OCSOC contain 4-digit occupation codes describing the respondent's primary occupation. We also offer up to 3 harmonized variables across IPUMS USA and CPS. As described earlier, each harmonized occupation variable codes all years of occupation coding schemes into a single coding scheme. To give you a sense of the amount of detail and change in healthcare occupations, consider these 2 sets of broad healthcare occupations in 2010 and 2017. So the healthcare practitioners and technical occupations was 29 categories in 2000 and 31 categories in 2017. The healthcare support occupations increased from 6 in 2000 to 11 in 2017. And these are some of the healthcare practitioners and technical occupations that were identified in 2000, just to give you a sense. So there are chiropractors, dentists, pharmacists, LPNs, registered nurses. There are a whole slew of them. There's quite a bit of detail there. In contrast, in 1990, there were 24 health occupations. So this is fewer than the 35 that were in 2000 and 42 in 2017. So if you wanted to look at change in the composition of the health workforce, you would have to navigate these occupation changes. Here's an example of how we do that during the harmonization process. You can see that 3 occupations in 2017 were combined into one OCC 1990 code during the harmonization process. So registered nurses, nurse anesthetists, and nurse practitioners and nurse midwives were all coded as registered nurses in 1990. So if you want to specifically study nurse practitioners and nurse midwives, OC 1990 isn't going to work for you. You can't identify just those types of nurses, but the detailed and unharmonized 2017 occupation data will work just fine. Now turning to course occupation coding, we focus on the National Health Interview Survey. If you want to study health outcomes, you'll want to use the NHIS, which has coarser 2-digit occupation codes available in contrast to the greater detail available in the other data sets. There is an unharmonized variable, OC, and a harmonized version, OC 1995, in the NHIS data. Here we will briefly illustrate the ways that detailed occupations are collapsed into 2-digit occupation codes in the NHIS. On the left are detailed 4-digit census occupation codes, like those that are available in USA, CPS, and ATUS. In the NHIS, however, this level of occupational detail is not available to researchers. Column 2 shows the course occupation codes that are available in the NHIS. Corresponding course occupation labels are in column 3, and you can see that in several cases, many detailed occupations on the very left are combined in the NHIS and can't be distinguished from one another. Despite the relatively large health workforce occupation bins in the NHIS, occupation codes still change over time and require harmonization. Here we illustrate how occupations are harmonized in NHIS. The primary trade-off is some loss of detail for comparability over time. So on the left are original occupation codes, and on the right is the harmonized OC 1995 variable. So instead of having 6 distinct occupations, as on the left in the unharmonized data, you end up with 4 after the harmonization process. So the first set of codes have a 1-to-1 correspondence between the unharmonized and the harmonized occupation variables. The second 2 occupation codes, 30 and 31, get combined and reassigned to code 301 during the harmonization process. Codes 32 and 34 get combined into code 805, health service occupations, during harmonization. And finally, code 32, nursing, psychiatric, and home health aides, get coded as health service occupations. So like I said, we end up with 4 harmonized health workforce occupation codes with the course NHIS occupation data. This slide is simply a summary of what we've described thus far. There are 2 major dimensions researchers must consider when they're thinking about how to use IPUMS data to directly identify the health workforce using occupation. And those 2 issues are comparability and granularity. We list the projects at the intersections of these 2 dimensions. I want to briefly return to the issue of defining the health workforce using occupation versus industry. While I focused primarily on comparability and granularity of occupations, the same types of issues apply for industries. So depending on your research question, you may want to use occupation or industry to identify the healthcare workforce. For example, if you want to study social workers who work in hospitals, you would find social workers using the occupation code and hospitals using the industry code. With that, I will turn it over to Julia.
Now that you have a sense of what IPUMS is and the different measures available to help you identify members of the health workforce, I'd like to turn to the kinds of topics you can study for the health workforce using IPUMS data. To give you an idea of the kinds of research that are available with IPUMS data, we have identified 5 general topics related to the health workforce. Describe members of the health workforce, characterize the nature of their jobs, depict activities outside of paid work, assess health behaviors and outcomes, and describe aspects of healthcare delivery or financing. You may be most interested in describing characteristics of health workers, such as demographic characteristics like sex, race, and ethnicity, and age, or other characteristics like earnings and education. Because of the availability of detailed occupation and industry codes, combined with large sample sizes, USA and CPS data are well suited to describe characteristics of health workers. In the following slides, I'll show figures from a study by Hegenes and colleagues published in Nature that used IPUMS USA data to describe biomedical scientists. We think this study gives a nice illustration of the types of questions that could be answered about the health workforce. In this graph, Hegenes and colleagues compared the size of the population of biomedical scientists they obtained using 3 different definitions of the biomedical science workforce in each decennial census from 1850 through 2010, except for 1890, of course, which was destroyed in a fire. And in this figure, they described the distribution of citizenship and naturalization status among biomedical scientists in each decennial census from 1980 through 2010. Another topic of interest to many health workforce researchers may be the attributes of jobs held by health workers. Both USA and CPS data contain measures about work and work-related information for both employed and unemployed members of the health workforce. In another example drawn from the Hegenes and colleagues study, they use information about work context to describe whether biomedical scientists were employed in public, private, or academic settings. The time diary data available from ATOS allows analysts to describe another topic that may be of interest, what health workers do outside of work. ATOS allows you to study the amount of time spent in sleep, physical activity, unpaid work, and so on, and can be combined with occupation and industry information from the CPS to describe time spent in such activities for members of the health workforce. For example, in this figure, we show the number of minutes per day on average spent in sleep, paid work, with own children, watching television, providing childcare, and exercise for nurses versus doctors. You can use ATOS and NHIS to study health behaviors of people working in the health workforce, as shown in the previous slide, and as we will show you in the next slide. You can also use NHIS to study occupational health and various health outcomes, such as low back pain and mental health, as well as healthcare utilization in areas such as complementary and alternative medicine, preventive care visits, ER visits, and hospitalizations. For example, you can estimate the annual share of health workers who received vaccinations for hepatitis B, influenza, and pneumonia from 2004 to 2018. In this example, we defined the health workforce as those who are health diagnosing professionals or technicians or healthcare support workers, and who also worked in healthcare and social assistance industries. Using MEPS data, you can study additional topics about the health workforce, such as provider characteristics or behavior that are related to accessible and high-quality healthcare or to satisfaction with care. Unlike other data sets, however, all of this information is collected from the person who is receiving care rather than directly from the healthcare provider. You can obtain information that is quite detailed about the specialty of the person's usual source of care provider. There are 17 different physician specialties and 7 different non-physician provider types that are identified. This graph depicts one aspect of healthcare delivery that is frequently discussed in the research focused on understanding racial disparities in healthcare outcomes. In it, we describe the share of people with a usual source of care provider whose race and ethnicity matched their own, broken down by the person's own race and ethnicity using information provided by individuals in the MEPS survey. In this case, we do not break these numbers down by the type of usual source of care provider, but we could imagine using the information shown on the previous slide to create an analysis that does. The MEPS is the leading source of information about healthcare expenditures in the United States. These are the amounts that actually get paid for healthcare as opposed to what is charged. So it generally reflects, for example, discounts from the hospital or agreed upon rates between providers and private insurers. Expenditure information is provided in the MEPS data, broken down by specific types of providers, both in terms of the setting in which they provide care and the type of provider, and by who made the payment. This is one example of the kind of analysis you could conduct using the MEPS data. In this graph, we visualize the trends in the average healthcare expenditures from all payment sources between 2000 to 2016, paid to office-based physicians, nurse practitioners, and physician's assistants, respectively. And in this example, we highlight the ability to combine information about the type of provider, outpatient physicians, with information about who is paying for healthcare expenditures and the amount of the payment that went to the facility versus the provider. As researchers think about which IPUMS data would be best suited for their research, we have a few analytic considerations we like to run through to help in making the decision a little easier. The first thing we advise researchers who are considering which IPUMS data product to use for their analysis is to think about the range of topics that they are interested in studying and whether there are data sources that allow for studying those topics in the same analysis. These next two slides visualize the availability and representation of specific topics across different projects. Larger dots indicate greater representation of those topics, and smaller dots, or no dot, represent little or no representation. Here, for example, we can see that all projects have pretty good representation of measures on socioeconomic status, but that HUS and the Health Surveys projects, NHIS and MEPS, have little information on housing. Perhaps most importantly for this audience, USA, CPS, and HUS have the most detailed information on occupations and industries, whereas the Health Surveys project data have little to none. And here we can see that USA has no information on health behaviors and little information on disability or health insurance, but that the Health Surveys projects have a lot of coverage of these topics. Another important analytic consideration is geography. Some researchers need to have information available at a state or lower level of geography to be able to use a data source for their analysis. However, very different levels of geographic detail are available across projects. In our microdata projects, the USA data will provide the lowest level of geography, which is the PUMA, or Public Use Microdata Area. PUMAs are geographic groupings defined by the Census Bureau that encompass at least 100,000 people. These geographic groupings change over time, and in some years may even cross state boundaries. IPUMS provides harmonized versions of these geographic units. USA, CPS, and HUS all have state-level information, although for HUS, analysis is best at a national level due to sample sizes. Both NHIS and MEPS are intended for nationally representative analysis, although both data sources include information on broad census regions, Northeast, Midwest, South, and West. Last, it is important to consider two aspects of time when selecting the appropriate IPUMS data for your study. One, the years for which the data are available, or a temporal coverage, and two, how often the data are collected. Here we provide a visualization of the periods of time for which each IPUMS data product is available. The USA decennial census data is available for the longest period of time, with data available beginning in 1790. CPS and NHIS have digitized data available starting in the early 60s. MEPS data have been collected since 1996, and HUS data collection began in 2003. And here we represent the frequency with which the data are collected, from low to high. The USA decennial census data are our most infrequent, of course, being collected only once every 10 years. The USA American Community Survey, or ACS, HUS, NHIS, MEPS, and CPS supplement data are all collected and or released only once per year. And the CPS basic monthly data are collected and released each calendar month. Switching gears slightly, although the focus of this webinar has been on IPUMS microdata appropriate for the study of the health workforce in the US, we also wanted to briefly note that we also have census and labor force survey data for other countries that could be used for the study of the global health workforce. The IPUMS International product family offers census and labor force survey data from more than 90 countries. For those countries that collect information on occupation, IPUMS International offers a comparably coded occupation scheme following the International Standard Classification of Occupations, or ISCO 88. One can use the IPUMS International data to identify persons working, for example, as nursing and midwifery professionals, other health professionals, and traditional medicine practitioners. And in their Global Health Observatory data repository, the World Health Organization publishes statistics on the global health workforce, drawing on multiple data sources, including IPUMS International. As Sarah mentioned earlier, we provide a host of useful resources to help you get started and support you as you use our data for your research. We provide video tutorials that walk you through selecting samples and variables from our website as you create a customized data set. We have a user forum where users ranging from beginners to experienced researchers who have used our data for years post questions and insights about the data. We provide data training exercises in SAS, SPSS, Stata, and R for each of our data product families. And you can always get in touch with our dedicated user support staff at ipums@umn.edu. So that wraps up the slideshow presentation. But now I'll give you a brief tour of the IPUMS NHIS website to give you a feel for how our websites look and how easy it is to browse topics and documentation, select variables and years, and create a customized data extract. Okay, so this is the IPUMS NHIS homepage. Most of our IPUMS websites look like this in some form or another, and you can start by looking at the contents of the left-hand menu. We have a lot of resources available here for you, including questionnaires, information about user notes, which is a great place to get started. And we report information here like sample sizes, give you information about the sample design, talk about the sampling weights, etc. And then we have other various topics, including occupation and industry variables. This is a longer technical note explaining. Returning to the home page, you can access our data in several ways. You could click Browse and select data here, select data up here, or just get data. Clicking on Get Data brings you to this page, which allows you to browse and select variables that are organized in these drop-down menus by unit of analysis. So these are variables that are about the household, variables that are about the person, and then variables about injuries. You can also select samples over here in this teal box. So if I clicked on that, you could see that we have data from 1963 all the way to 2018. I'm going to select all samples just so that we can keep looking at all variables. But if you select a smaller set of years, only the variables that are available in those years that you selected would appear in these browsing windows. And I'll look at the person level variables, and we've got them organized into topical groupings. So here are demographic characteristics, socioeconomic status, and here under work is where your occupation and industry variables would be located. There's general health status, there's linked mortality data. So for respondents between 1986 and 2014, their information is linked to death certificate data. So if you're interested in studying mortality, that's a great data source. And then all the way down, and I'm just going to point out the vaccination variables that I used to create that graph in the slideshow are located here. We have complementary and alternative medicine variables here, and then our mental health variables are also extremely popular. So there's the Kessler-6, as well as measures about anxiety, depression, panic attacks, and so on. Here we have health behaviors, where we've got alcohol consumption, smoking, physical activity, and so on. And so, as Sarah mentioned, you learn one website, it's much easier to learn each one. So most of our websites are organized in this way. I'm going to go ahead and click on work. And this brings me to a topical grid. These are variable names along with a short variable label. And this is our variable, our availability grid. And on our website, it's organized from the most recent year, 2018, all the way to the earliest year, 1963. These X's mean that the variable is available for that year, and the dots over here mean that that variable is not available in that year. I can add these variables directly to this data cart I have up here, which tracks the variables that I've added. So notice that I've added 56 samples, and then as I add variables to my cart, let's say I want the unharmonized and the harmonized versions of occupation and of industry. Notice that that increments my data cart up as if I'm shopping for variables. And let's say I'm also interested in whether these workers have paid sick leave, whether they're paid by the hour, and whether they have a second job. And then let's also say that I'm interested in sleep problems. So under health behaviors, there's information here on sleep. And I can look at the number of times in the past week they've had problems falling asleep, staying asleep, taking medication, and the number of days that they woke up feeling rested in the past week. I'm going to view my cart. Oh, and it will update with all of these new variables that I added. I'm not quite ready to check out because I just want to give you a sense of what these websites look like. So if I click on a variable name, it will bring me here. I'm just going to make this a little bit smaller. And across the top, you have these different tabs describing different kinds of documentation that are available for this variable. These are the codes. So it ranges from 0 to 7, and then there are missing data categories. Here's a description of what the variable is. Here is the original survey text that was used to collect the information in each year. So I could just click through all of these. This identifies whether there are any comparability issues over time. We see that sometimes with our variables that have been available for longer periods of time. This variable is asked of sample adults aged 18 and older. And you should use the SAMP weight variable to analyze this. And then if you're a user of the original NHIS data, this is the name of the variable in the original NHIS data, and this is where it is collected. I'm going to go back to view my cart and create data extract. This gives me a summary of the variables that I added to my cart, the number of samples. The default is that you would get this as a fixed width ASCII text file. You can change that. So I could just request this as a STATA, SPSS, SAS, or CSV file if you're an R user. I'm going to stick with the default. You can add characteristics, and we go into this in our IPUMS NHIS webinar that is posted to our website, but I'm going to skip that for now. And then you can describe your extract, and then I would submit my extract. It's going to prompt you to log in. Our data and services are available free of charge, but we do ask that you set up an account, and we just ask you a little bit about yourself, your affiliation, and then you're ready to go. And once you set up one account, then you can access pretty much across the board all of our projects with the exception of IPUMS International, which has a separate registration system. And then if I were to go ahead and submit this extract, I would get an email in, I think we've been getting extracts in about 6 minutes, letting me know that this extract with 56 years of data and 27 variables is now available for download, and possibly as a STATA file if you're a STATA user, and you would be ready to go. We have more information on our website about how to download those data, how to read them into your stats package of choice, and then how to start browsing those data. So that wraps up my portion of this talk. We hope you found this webinar a helpful aid in thinking about how to use IPUMS data for your next research project. We look forward to hearing your questions. Thank you so much.
Great, thank you very much, Julia. I'll just start off. We have some questions in the chat box. We'll get to those in a minute, but I just thought I'd start with a kind of a basic question. If I wanted to study a specific occupation, let's say registered nurses, what would you say are the best options in terms of data sets and variables? And maybe I would qualify that by asking, how can I quickly determine if the detailed occupation I'm interested in is available in which data sets?
All right, thanks for the question. As we talked about, the NHIS is not going to have the occupational detail that you would need to study registered nurses specifically. For that, you would need to use the ACS, the CPS, or the American Time Use Survey. And at that point, I think it depends on what outcomes you want to study. if you simply want to describe the population of registered nurses, I would say your best bet is the American Community Survey. It has the largest sample sizes, and you will have the largest number of registered nurses in your data set. And the way to quickly discover whether a data set has the occupation that you care about is to go to the IPUMS website. You can either browse through the variables and find the unharmonized occupation variables, typically called OCC, or you can use our search function to search for occupation, and you'll see, the link to the variable will come up, and then you can just browse through the occupations. Typically, when I'm on a variable codes page, I just search, especially if I'm looking at occupations, because there are hundreds of them listed under the detailed occupations.
And I see that some folks have asked specifically about, I would say, emerging or relatively new occupations like community health workers, patient navigators, and care coordinators. And you may not know off the top of your head about those, but I think that partly inspired my last question. If they're not available now, any idea when they might be? I know there's an updating process for the standard occupational classification system. I wonder if you could comment on that.
Yeah, that's a good question. Right, we don't code occupations, so we don't know when they'll show up in the data, but we do know that there has been an update to the occupation classification system in 2018, and we're not up to speed at the moment on what those changes are, but as those occupations grow, it's quite likely that they will show up eventually in the occupation coding scheme. And it looks like one of our colleagues just took a look for us. It looks like community health workers are in the 2018 SOC, but they may not make it into the ACS or the ACS or the CPS data. But we'll have to take a look. Okay, so we saw one question that was about, the question was, if I link ATUS to CPS, can I get a lower level of geography than state? And so we actually have CPS, public use CPS geography on the ATUS files already. And I can tell you that about 45% of households in recent years are located in a county that is identified in the data. So about half of people have no county information in the public data because they don't live in a county that's big enough to be identified. Yeah, and there's another question about the availability of metro and non-metro information in IPUMS data. So metro, so you can identify metro through 1996 for NHIS. There's also a measure of MSA until 2001. And then in the MEPS data, you actually have MSA through 2013. Okay, and we're seeing a question on the chat. Does IPUMS have internship opportunities for graduate students, especially those intending to use ACS and CPS data sets for their dissertations? We actually just had a call up for workshops. It has expired. We're having a CPS workshop this summer. We don't have a ton of workshops. We have lots of materials online to help support researchers, such as tutorials. And in lots of cases, we also have exercises that we point researchers to if they want to understand how to use our data. And I'll just plug our user support team again. They're really fantastic for general questions about the data, even specific questions to help you move forward with your research.
It looks like there's another question here about, just to clarify, in terms of studying rural health and health force, MEPS is the best bet. I wouldn't say so, just because you wouldn't know if they were rural. I would say that ACS data would be the best bet because you would actually be able to identify whether they're in a rural area, and you would have those detailed occupation codes that would allow you to identify, for example, the number of nurses that are available in rural areas in Minnesota, where we are, or Alabama, or wherever. And so it seems like that might be a better data source. If you would want to use MEPS, you could have MSA up through 2013, so it would be an increasingly dated portrait of the rural health workforce. And I would only do that if you wanted to figure out information about healthcare financing, but it's such a quick-moving field that I don't know if I would recommend using 2013 or older data unless you had a specific research question that made you want to look at that time period.
All right, now we're looking at the question from Gretchen about, that says, I'm interested in workers that would be substitutes for unpaid family caregivers. How can I look at the definition of occupations to see how each code is defined? Basically, what you would need to do is think about what are the jobs that are coded into particular occupations, and in terms of where to find that information, we only have the coded data on our website, but if you send an email to ipums@umn.edu, we can do a better job of answering that question after the webinar. So I mentioned that the time use survey can be merged with CPS. I'm not going to be able to show you that here. There are detailed instructions on the ATUS website about linking to CPS. In the left-hand menu of our homepage, you'll see a link that says link to CPS. This is the beauty of using IPUMS. We've made it quite easy to do that. We have a unique identifier called CPS ID on both the CPS and the ATUS files that you can use to easily merge ATUS and CPS. Also, I'll plug a workshop that we have at PAA in April on this very topic if you are interested. There's a question about topic coverage for ATUS is larger if linked to CPS. Yeah, I'd say that's fair. Basically, anything that's in the CPS can be analyzed in combination with data from the time use survey if you are willing to link the data sets together. And I think we've done a pretty good job of simplifying that process. A lot of people aren't doing that. So there's space to be innovative there.
Okay, so we have a question here about, can people be linked across years or are they sampled in more than 1 year of data? So some of these data sets are cross-sectional. They're only collecting information about people at a single point in time at the time of the survey. Other ones, however, follow people over time. And so we do have a couple of longitudinal data sets. Specifically, we've got CPS and MEPS are both longitudinal data sets. So CPS actually interviews the same household, members of the same household, for 4 consecutive calendar months. Then they stop following them for 8 calendar months, and then they follow them again. They go back to re-interview the same household for 4 additional calendar months. So you have 4 observations on the same household across 2 adjacent years. And then for MEPS, you actually have people, the same people so it follows people and not households, are interviewed 5 times over 2 years.
There was also a question from the audience about whether nurse practitioners, physician assistants, and physicians were identifiable in the NHIS. We've taken a quick look at the data, and we are not seeing those occupations as distinctly identifiable. They would probably be under healthcare providers. So you would need to go to like the ACS or the CPS or the time use if you're really interested in that population or a different data set.
Yeah, and you can identify them in MEPS, but again, it would be from the consumer's perspective, and it would be this information that's reported by the consumer about their usual source of care provider or about their healthcare expenditures broken up by type of provider.
I'm not sure we did a great job of answering this question, which was, can we assess whether metro or non-metro county? So the answer is yes, if the county is identified in the CPS. If the county is identified, you know both the county that the person lives in, and whether it's a metro or non-metro area. And in ACS, I believe you can actually do a little bit better. So that would be USA.
Okay, well, we're right at the top of the hour, so let's go ahead and begin to wrap up. With that said, I'm going to ask for some final thoughts. Julia, Sarah, do you have anything you would like to share with our audience before we take off today?
Send us an email if you have any questions. We're happy to help.
Yeah, we've got additional resources, and yeah, we'd love to hear from you.
Great. Well, I'm just to let you know that was a very informative presentation. I was very impressed. Davis, thank you for joining us today. Do you have any final thoughts or anything you'd like to share before we take off?
Oh, no, I just want to thank our presenters, and I learned a lot, and I hope our audience did as well. Thank you very much.
All right. I think we'll go ahead and end today's event. Once more, this event has been recorded, and it should be available on our website within a week. So for those of you in the audience, thank you for attending, and we hope to see you again in the future. Have a good afternoon.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.